there's this big blood vessel that comes off the heart called the aorta, and comes up and feeds the upper body and goes down, feeds the kidneys and the bowels, and that artery can sometimes swell and create because it becomes something called an aneurysm. And we both graduated from medical school the same year. We both have seen amazing advances in our respective fields. Just amazing. We're in a different world nowadays, what we can do now versus what we had to do. And I know when one of these aneurysms gets real big and starts to explode, it's called a AAA, an abdominal aortic aneurysm. And I will never forget when I was a medical student, having somebody with these purple bruises on the belly and a backache and an x-ray, and the surgeon said, this is a rupturing aneurysm. I remember being the assistant. They used to open the belly all the way, and if it was bursting, the blood would be just pouring out. I remember them putting the clamp on the aorta, and I would hold the clamp, and I'm feeling it pulsating as they would cut out this swollen aorta and put in a graft, one of these artificial fiber grafts. And a lot of people would die, and it was a very bloody procedure, and it was risky, and it was a lot of drama and whatnot. But I understand that you now can do something much more elegant for something that's life-threatening and enormous, such as a AAA. So would you tell us, what can you do about these aortic aneurysms that we could not do when we were medical students?
Well, as a matter of fact, abdominal aortic aneurysms are one of the more common aneurysms that we see in our patient population in their 6th, 7th, and 8th decades of life. And these aneurysms develop, we used to think that they developed from and they do, from a degenerative process, but we kind of had it wrong. It turns out that these aneurysms are familial in some cases, related to nicotine in a lot of cases, and related to some different enzyme deficiencies, if you will, in the wall of the artery.
So it runs in families, and there's a metabolic component. So
yes.
So you definitely could have a tendency or propensity to make one of these.
Exactly.
Interesting.
And in fact, if you did an abdominal aortic ultrasound of everyone's abdominal aorta over the age of, say, 65 to 70, you'd probably find an aneurysm in 2%, 3% of people.
A significant one, like a life-threatening one, like it could go.
No. You would find just an aneurysm. And an aneurysm is defined as 1.5 times the normal diameter of an artery. So the abdominal aorta is typically in a man somewhere around 16 to 20 millimeters in diameter.
Okay.
And so you'd find an aneurysm of 30 millimeters or higher in that percentage of patients. And you would find a significant aneurysm if you coned it down to where you're just screening people who smoke. Then you would find more significant aneurysms than if you just screen the population at large.
And
what I'm getting to is it's not an insignificant finding. Now, we don't fix these aneurysms until they get large enough to burst. And what size is that? Well, it's about 55 millimeters.
Wow.
And so we watch an awful lot of them from, say, 30 to 35 all the way up to 55. And then we start repairing them at 55 because we know that's the size that the risk of the operation is less than the risk of rupture. It's about 55 millimeters for most people.
Gotcha. So what are these amazing things you can do now so you can avoid these enormous, bloody, risky operations?
In fact, it's been deemed the most significant advance in vascular surgery in the last 100 years, the endovascular repair of an abdominal aortic aneurysm. And the thing that basically is done is that you go through the groin arteries or the femoral arteries down in the groin area, and under X-ray, you're able to put covered stents inside the aneurysm.
So you're not opening the belly at all.
Right.
First of all, a lot of these cases, you're threading a tube in through the groin, and through that tube, you have a device that goes in and expands and essentially relines the aorta. Is that what's happening?
Yes, it redirects the blood flow from the walls of the aneurysm. So it takes the pressure of the blood off of the wall of the aneurysm and now exerts the pressure inside the covered stent so that you don't get that pressure, that bursting pressure, if you will, of
Yeah.
the aneurysm wall. And if you don't have that bursting pressure, then typically the aneurysm sac will shrivel down around the stent.
The new inner
And it's
tube.
amazing.
I
It's
love it.
amazing. So
I
we
love it.
started doing those in 1999 at Boone Hospital. A retired partner of mine now named Kurt Vogel, Paul Humphrey, and myself. And in 1999, we started doing these things. And believe it or not, I still have a couple of patients from 1999 who we follow once a year, do an ultrasound just to make sure that the endograft, as we call it, the
Okay.
covered stents, looks good and that we don't have any problems associated with that.
And they're still
It is
alive.
amazing. And let me just say this.
Please.
When you and I were in training, those patients you're talking about would be in the hospital anywhere from minimum of a week all the way out to 2-3 weeks.
Yeah, long
And that's
time.
if things went pretty darn good.
Yeah, without a major complication.
Yes. And the risk profile was 15 to 20% for heart attack, stroke, kidney failure. I mean, all kind of, if you name it, it could happen with an aneurysm. Nowadays, with our endovascular repairs, the risk profile is somewhere around 3 to 4% all for everything.
Wow.
And the major risks are about 1% or less. And almost everybody goes home the next day.
That's
It is
fantastic.
absolutely amazing.
Wow.
And I'm still, what is this? This is 24 years later almost, 23 years later. I'm still amazed at that we can do that. It just revolutionized the treatment of aneurysms. It really did.
Yeah. Now, what if an aneurysm is bursting? Can you still do that?
You can. And there are a number of studies to show that if you treat a ruptured aneurysm with endovascular techniques, if you can, we can't treat all of them with endovascular techniques. I would say 80 to 90% we can. There's still some that we cannot. But if you can treat it with an endovascular technique, the chance of survival is much better than if you have to go in and do an open repair like you alluded to earlier.